You will know our speakers well if you've been tuned into our previous webinars. We are joined today by Professor Tim Spector from King's College London and Jonathan Wolfe, who is the CEO of Zoe. We have created the COVID Symptom Study technology, as well as a lot of the machine learning and data science function that's going on. Tim, some words on our donation scheme?
Yes, so really on behalf of the project and Zoe, really just wanted to thank the 44,255 donors who gave us money for this appeal, really to keep the app going and this amazing project going for the next few months until we try and secure some funding from charities and the government. And we really couldn't have done this without you, and it was a real fantastic buzz for us all to see that clock ticking up and realize that there's other people as passionate about this project as we are. So fantastic, thanks. The money's with the charity, the CDRF, so that really gives us great reassurance that we can carry on and keep delivering these great results at this really critical time. So thanks very much on behalf of all of us. And the other bit of news is that since we published our paper on the 11th of May in Nature Medicine about how you can get a virtual diagnosis for COVID without needing a swab, using just this collection of symptoms and an algorithm that gives about an 80% predictive value, we're actually launching a trial to test the Zoe algorithm to see whether in real time we can, by predicting already who we think is going to have a positive swab test, we can actually prove it in real time. And that would, if it all goes well, allow us to then actually market that around the world as a potential tool that people could use in places that don't have access to swabs. So that's a fantastic thing that's got going. We've got all the ethics in place, and about 50% of you have already signed up for this. So it's, I think so far over 500,000 people have agreed to do this trial, which is a fantastic scale for anything. So we're going to start that off soon, sending people invites depending on their symptoms or not to get tested. And so we should get those results really fairly quickly within the next few weeks if everything goes well. So thanks very much for that.
And continue to ask everyone who hasn't yet signed up to do so, because the more people we have on the study, the sooner we'll be able to come up with something that hopefully really works.
Yeah, so it's no great commitment on your part to do it. It's really just for the various ethics. You're not really doing anything very different to what you've been doing before. It just we just need that tick on a box so you can go ahead. So if you haven't done, go back and tick it, or if you're happy to just be part of a study that we can write up and actually publish. That's the main reason for doing it.
Now, Tim, there's a question of whether or not this study is available for those who are in Scotland, Wales, and Northern Ireland. Where are we on that front?
It is in Northern Ireland, and we're still negotiating with Scotland and Wales at the moment, who say they want to do it. I think they're just waiting to get all the local testing facilities up to scratch so they don't disappoint people. But I think that best to assume that to sign up for it, and hopefully we'll have some good news in the next week about those two places.
Great. Now there's quite a few questions on where people can find the box to tick. Jonathan, do you want to explain the process of how people can get involved?
Yeah, absolutely. So the first time you have the opportunity to sign up for the study, you'll see this ad like you see on the right-hand side. We are actually now, if you've seen this ad, you were busy or you weren't sure at the time, we're actually releasing a new version of the app later today, which will allow you also to opt into the study after you get to the sort of the finish page, after you put in your status, and we will be putting another a page probably later next week for people who again haven't decided yet whether they want to do it, to be able to join. And we will be sharing more information around the study. The big focus, as Tim said, was really just getting it off and launched. We will share some more details about it in the next few weeks. It's a sort of ongoing process as we look to further improve the machine learning models to predict COVID and try and see whether we can do that a lot faster than in a situation where, you know, once you're sick, you have to get a test, you have to wait to get the test, you then have to wait to get the results of the test. And we're going to talk a bit more about track and trace at the end, aren't we, Tim? But we feel that, you know, the time to know whether or not you're infectious is really key, because, you know, if you could know sooner that you were infectious, obviously you would change your behavior at that point. Absolutely.
And there's some questions here around, you know, if I had symptoms weeks ago and, you know, I wasn't tested at the time, if you have gotten an antibody test, you can add that into your app. And there are quite a few antibody tests available in the UK through different healthcare providers. So that's the option there.
Yeah, and about 25,000 people, I think, have actually had an antibody test, we think, so far on the app. So we are slowly building up this data, and many people who work in some of the hospitals are getting access to it. And there are also a number of private companies also offering it. So hopefully this is going to get more common. But as you know, antibody tests are also not infallible either. So there's no gold standard. That's why a combination of all these things is going to work best.
And Sandra has asked probably the most unique question we've had on one of our webinars. How can people who live aboard a narrow boat and continuously cruise with no car or access to a COVID test get a test? Any ideas, guys?
I guess you'd have to get your test. You could ask for a home test kit and get it delivered to the nearest lock, or someone you know along the way, and they can cycle it and drop it on the towpath.
Good.
Perfect.
Perfect. We've got a few other news updates around the science that we're doing as well, Tim.
Yeah, so some of you might have noticed today we published a letter, a research letter in the Lancet, basically in a follow-up to our data on the sense of smell. You might remember on the 11th of May, it was the 1st of April, it was, I think, when we had this, sorry, my dates mixed up, but a few weeks ago, the government said that they were adding loss of smell to the cardinal symptoms. When questioned, they said the reason they hadn't done it earlier was because it was a very small effect on top of the other two, and only about 1 or 2%. We weren't sure what data they were using, so we decided anyway to do a more comprehensive analysis. And this is based on 13,000 people who'd had a positive test, and many 100,000 more who hadn't, who got a negative test. And you can see from this Venn diagram that loss of smell in the red is really very common, and in people who don't have fever or cough, it's 16%. So that's a huge number of people that you'd miss if you just took fever and cough. And on average, it lasts 5 days. Loss of smell, and fever only lasts 2 days. So we think as a screening test, it's going to be really important, and should be used much more in schools, hospitals, maybe airports, other places like this. So this is a whole potential public health thing that we wanted to alert everyone to. And so this is a very common symptom, and it's not trivial as has been suggested. And the other area that's in the news at the moment, of course, is the ethnic minorities having higher death rates from COVID. It's not been known before whether the infection rates are higher or not, or it's just that the effect of the virus is more severe. And we're doing this study now, and we've got some results in the very early stage of writing up from our app. And it's looking so far that actually the infection rate is increased as well. So that's going to be interesting to work out why that's happening. We're going to confirm that in the next few days and hopefully get an early report out within a week or so. Just thought you wanted to know that. We are looking into these, particularly in the UK, but also in the US, the role of the disease in these groups.
Absolutely. And I think it's important that particularly in the United States, we're looking at a number of cohorts, including the multi-ethnic cohort and the Black Women's Health Study, which we've mentioned here. And if you go on to covid.joinzoe.com on our blog, we've written a piece on the importance of health equity in light of the events that are going on in the United States and affecting people around the world. So if you're looking for more information on health equity and research and some of the things that we're doing or places to donate to, please have a look at our research blog at covid.joinzoe.com. Quite a few of you have asked, how do I log an antibody test in the app? So if you're in the section around testing, if you note blood test and then say whether or not it was negative or positive, then that's the best place to log it at this stage. So moving on to the story since lockdown, we're going to briefly talk about some of the results that we've had over the past few months before we get into the incidence data that we're seeing now. So Tim and Jonathan, do you want to talk through what we've seen around prevalence?
Yeah, absolutely. So firstly, I think this is a slide that everybody will have seen for a long time, which is really the total number of people, on each day since lockdown that have symptomatic COVID. And so what you see is we saw this big peak on the 1st of April, shortly after lockdown, rapid decline within lockdown, then slower decline, and then slower still. So this is sort of the long-term context to where we are. And then today, what Tim and I thought we'd try and do is talk a lot more about where are we right now, share quite a bit of data that we haven't been putting on the website because it was more detailed, and then talk about where do we think we might go from there. So if we shoot forward to sort of what is happening now. We just updated this data in the last 24 hours. And the good news is that daily new cases in the UK are continuing to fall. So they're down 17% from last week. We think this data is really quite robust, and we can talk a bit more about how we gather it. So down now to 9,400 new daily cases, and the graphic on the right shows you basically the number of new cases per million people, which we think is the easiest way to compare between different regions, because it gives you a sense about your risk as you go about and just meet individuals. And what you can see is that there continues to be a significant difference across different regions. And in the next few slides, we'll talk a bit more about that, and Tim will discuss a bit more why that might be the case. If we go on to the next one, we thought it would be interesting to actually look at where these infections are happening right now. And so what we've plotted onto the sort of the same chart that you saw on the previous page is a dot for every app user who reported a recent positive COVID test. And we looked at the last 14 days because that's a reasonable time period to think that somebody might still be infectious. And in this period, we have 1.5 million UK users who reported 63,000 swab tests, of which 2,600 of them confirmed current infection. So these 2,600 dots. And I think the thing that is most interesting about this is that the dots are spread all over the country. And I'll let Tim maybe comment a little bit more.
Yeah, so obviously London is where you're getting most of them. And so the idea that it's petered out is obviously not true when you actually see what's happening here. But the key is that it's in pretty much every part of the country to different extents. So there's nowhere really that has absolutely no cases. maybe apart from the very far north of Scotland, the Shetland Islands. And of course, we're seeing a fixed proportion of the population. So each day we're sampling about a million people, and we're asking those people how they're feeling, and if they're not feeling great, then we send them an invitation for a swab test. A proportion of those get it done, a proportion of those are positive. And it's from that proportion that we work out what percentage of the population on that day would be positive. And that's basically what we do. We then adjust the rates for the different regions in terms of people of different ages and things like deprivation index and other things to just adjust the regions so we're treating them in a similar way. And if we see the next graphs.
So Tim, just before we go on to that, maybe just for a second, there's some questions around how this compares with ONS data.
Yeah, no,
so just if we just hang on for 1 second before we move on to this slide. And Tim can also talk a bit more because we share this data daily with the government and they look at it compared to various other models. The great benefit of the app is vastly more people are engaged, and it's thanks to everybody on this call and many others. So this means we have this very large sample of people. We actually have more than 1 million people who we know are healthy and then go sick. So that's a much broader set of people than anybody else. And then a number of swab tests that are about the same. But of course, there are always biases in all samples. So our sample is biased towards the people who choose to participate in the swab tests, just like people in the ONS on theirs. We would actually view our data as being pretty in line with the ONS data that we've seen, and much more so, in fact, than many of the other things that are out there. And I'll let Tim comment if he has anything he'd like to add.
Just the ONS data basically is looking at a set number of households across the UK that are supposed to be representative of different ages, different races, different social class, etc. So they're taking a much smaller sample than us, but in a generalizable way. And they're also including swabbing children. So that's their model. And I think at the moment they are doing about 20,000 swab tests. So that's they're doing less swab tests than we are, and they're obviously focusing. I think it's about 4,000 households is how they're doing it. So they don't have the detail to look into the regions in as much detail as we do, but they probably are slightly more generalizable. So I think looking at the two is very useful, and that's really what we're doing. And the latest estimate they had was around 8,000 new cases a day, and they're updating theirs every couple of weeks as well. So did you want to, shall I carry on talking about this, Jonathan? So this
Go on, Tim. Yeah, absolutely.
This is the symptom app. So we haven't shown this before. We share this with the government's NHS every day. But basically, it's showing us that there is a difference between the number of cases depending on where you live and whether that's a deprived area or not. And so you can see here in the most deprived areas of the UK, we're seeing say 71,000 cases compared to 55,000 in the better off places. So there's a clear gradient that number of factors influence that, which we take into account. And the other factor is that the age effects, which are also interesting. Actually, I haven't seen these myself, they're so new. So we've now got 250,000 children who are being logged by their parents, which is great news. And you can see in this group here that the rates for children are really very low, and the highest group is around is age 20 to 29 to about age 60, and then it drops off again. So children.
And Tim, I just add, you know, and our reason, just to be clear, because you might be surprised by the higher age group, is to remember this reflects people in the app. We're collecting very little data from care homes. And so in general, this reflects the fact that people are shielding more as you move into particularly above 70. And so you see, you know, this marked decrease in the people who are getting COVID, with a sort of broad group between sort of 20 and 60 that looks fairly comparable.
Yeah, so that's the first time we've shared this data. And so each age group, as well, you've got the social factors as well as the potential factors of the virus infection itself. But we think they're an interesting look at what's going on.
Then the next thing we thought we'd, sorry, go on, Tim. So then the next thing we thought we would do was sort of say, are things getting better? And I think this in particular is where our data can show what's going on right now in a way that even the ONS survey, which we think is very valuable, is not able to get at. And again, here we wanted to share a set of data that actually we literally just pulled together over the last few days. So no one has seen this yet. So the first thing is we look at actually how many people are falling sick. So this is not the people who are sick, but actually people who are healthy the day before and then report that they're sick. And what you can see is the number of people who are falling sick right after lockdown was very high. You were at sort of 4% of people falling sick. And this declined, you know, very rapidly up until about mid-April. And then we've seen a slow decline up until probably, you know, I guess about the 20th of May, and then it's been basically fairly flat. Now, not all of these people have COVID. And Tim, do you want to talk a little bit about how you interpret this?
Yes, so obviously there's noise here from other ailments, things like hay fever, etc., which we're now just added to our app to try and separate out effects of good weather and people being outside in parks and things, and getting sniffles and allergies, and there are these day-to-day variations which we do see in quite a lot of our data. So it's just important to really look at the major trends. So only a proportion of these people will have COVID, and only a proportion of them will actually test positive with a swab. So it's very much just our base group, but because it's pretty you know, there's no fancy questions here. It just gives an idea of the general well-being of the population. And before we go on to the more detailed graphs, this is the number of new cases. So this is on any one day how many new cases there are on people who were previously well. And if our best data is from the top left-hand corner, the number of daily new cases in England, because that's where we've got the biggest numbers. And we're getting these routine swab tests, so our precision that we're not biasing it towards healthcare workers or other groups that are tested non-randomly is much more secure. And we can see that there was this real reduction during lockdown that kept going down, and then you can see 1 week after lockdown, where the arrow is, things start to even out, and the rate of decline drops, as you would expect, as people go back to work and get exposed again to some extent. But overall,
we should just explain the yellow lines, Tim. So the yellow line is the range that we're 95% confident the true value sits within. So the blue dot reflects our calculation. This is a rolling average of the previous 2 weeks. But the yellow line, you know, there's inevitably some uncertainty because we're just sampling. We don't have everybody in England on the app. But you can see also in the yellow line, just as Tim says, you know, a very clear sort of steep fall up until about 1 week after lockdown eased, and then afterwards you see what is now still a fall, which is what we see with the overall figures, but a much, much lighter fall when we're looking at England on the left-hand side.
Yeah, and these are the 95% confidence limits. And if we look at the regions, Northern Ireland, we didn't have much. Scotland, we don't have much to hard data yet.
Sorry, can we go back?
But Scotland, still the trend is downwards, which is good, as it is in Wales, with those large confidence limits, because we just need more people to be logging there as well, in both cases. So in the region,
and in particular, Tim, as you mentioned, that we, in the UK, we have the support from, in England, we have the support of the Department of Health and Social Care, which we're very grateful for, which is allowing us to get these very large number of tests done. We don't have that in place at the moment in Scotland or Wales, or the quantity of testing in Northern Ireland, which is why you have, this sort of still high degree of uncertainty.
Yeah. So general trend is downwards. That's the message here, although it's fairly slow. And if we look at the next slide, we get to see some of these regional ones. And what's really interesting there's two things to look at here. One is the direction of the graphs, and the other is the level of them. So if you look at the ones on the right, which are from the north of the country, the northwest, which was the highest last week, has now come down to be pretty much equal to the northeast, although it seems to be flattening off a bit. And then you've got, so they're still higher in the north than in the southeast, London, or the southwest. The southwest, that's of Somerset, Devon, Cornwall area, really good results there, rates going down progressively, very few numbers of new cases, seems pretty clear cut. In London, the last fortnight has really not seen any major changes in the incidence rate, which suggests that if you've calculated formally, which we haven't done, you'd see an R value which would be very near 1, whereas in the southwest it would be well below that. So nationally, we're seeing generally a picture that's reassuring. There are some regional differences, explaining why the north is still higher than the south, and why London's rates are flattening off and not going down as fast is important. And just to bear in mind that some people are saying that they know about other estimates for R for London a few weeks ago. These are based on deaths. So actually, modelers have used hospital deaths to work back and work out what the infection rates are. And we believe they're much less reliable, but there's lots of assumptions there than actual data based on swabs that ourselves and the ONS data have.
And maybe just there are a few questions, Tim. So maybe I didn't explain as well as I should have done what we've done, just to build on that. So if you take London for example, but the country overall, we have about 1 million people who are in this healthy group who've been reporting very consistently that they've been healthy over the previous 9 days. On any one day, about 1% of those people report they're sick. So that's about 10,000 people. We actually ask all of those people to be tested, not just the people who we believe are sick, because we want to get very accurate data, and we know there's asymptomatic cases that we would miss, and therefore that's why we have so many people we test. The number of people who end up actually having COVID is just a few percentage points on this now. Obviously, it was much higher at the end of lockdown, and so because of that, we're basically sampling, from this population of 1 million every day, and getting these very up to date figures. And so I think the R, we have not yet calculated this. We probably will share some data on that in the next few weeks. But you can see that for London, if the number of cases is very flat, then your R is pretty close to 1. And just as Tim said, that's because this is now very up-to-date view because of your participation versus a lot of other models which are themselves they're not saying anything that's untrue, but they're actually quite historical.
Now, guys, there's a question on whether or not this includes care homes as well. Do you want to talk a bit about how much information we have around care homes?
So so just to be clear, this doesn't include most people in care homes. The only people that in care homes it would include is if someone was logging for a relative in a care home, and we think they are relatively few of those. So we might be underestimating the cases if there are, as we expect, large amounts in care homes. But on the other hand, we are including people in healthcare, and some of them do work in care homes. So we're capturing some of it, I would say, but we're probably not capturing all or the majority of it. So that's one reason you might be underestimating.
There was another question, and just to be clear, we are covering all ages. There was somebody asking whether we were covering people over 70, and this data is covering all ages now. So care homes is where we believe we have a big gap, which it's just a weakness in the data, right, Tim?
Yeah, nobody's got good data on care homes, because I don't think even the ONS doesn't go into enough care homes to be able to extrapolate that.
Tim, a couple of questions. One from Tony. How do you accommodate false negative test results?
We don't at the moment, because there's no way of knowing exactly what that false negative rate is. So I think we just have to accept that there isn't a gold standard diagnosis of COVID, but for our purposes, we are using the swab test, actually someone proving that the virus is there, to use for all our models. Otherwise you can't, you have to use something as a basis for it. So that's what we're using. So it's a very good question, but unfortunately it's a problem that everyone in this whole field is facing.
Okay, and then just another question from Mayor. Do you think cases are not dropping in London as more people are commuting since mid-May?
I think there's a number of reasons. I think commuting is one of them. Going out more to shops more. People are probably going more frequently to supermarkets, interacting with more people. People moving around the country a little bit more. I think it's just the general movement of the virus is more when people aren't completely locked up. I don't think we can separate out the all the different reasons at the moment.
I think the only thing I would add is, if you look on the slide, it is basically flat, is in fact still at lower levels than we're seeing in the north of England. So it is flat, but interesting, actually, it remains lower than in the north. And the dot picture that we showed earlier obviously shows a lot of concentration in London. That's because there are a lot of people living there, and per million people, it's actually lower. But it is true that it is not continuing to decline. And I think, we're about to talk about the future, but I think that, what is clear is that we have eased lockdown, while levels of infection are still relatively high compared to many other countries in Europe at the point that they came out, and that we are continuing to see, infection in the community, in a very, broad way across the United Kingdom. Yeah,
so it's an interesting question whether you'd rather be at high levels going downwards or at low levels staying flat. So, nobody really knows what it is, but it's just showing the delicate balance I think the whole country is in, and that's been expressed by a number of scientists as well. And these data really support that. Again, broadly down, but some areas where, it wouldn't take very much for it to start going up again.
There's another question here from someone who is anonymous. Are you looking at sub-regional differences, i.e. urban versus rural?
Well, we have looked at that in our in the whole data set, and there's a paper certainly in preprint that's out there that does show even when you take into account density and deprivation, you do see more cases in urban setups than in rural. And that might be because people spend more time inside than outside. which has been widely accepted as harder for the virus to transmit outside than inside. But I don't think we have the ability within our data set to really separate that out within regions. That's not something that's very easy to do. We could probably do this nationally to see where the rates in people are doing, divide to two groups, rural and urban, and do a graph. That's an interesting point. We might look at that.
Great. So I think we'll move on to the question around what are the risks of a second wave? And I think there have been quite a few questions coming into the Q&A in the chat around, can I go on holiday? When can I go on holiday? Everybody wants to go on holiday. Is it safe for my kids?
I want to go on a holiday.
We all desperately want to go on a holiday. And as somebody mentioned earlier, Tim, who very much deserves a knighthood for all of this work, definitely needs a holiday. So guys, why don't we start with children in schools? What do you think some of the risks are, and do you think it's safe for kids to go back to school?
Well, I'll start with that one. I get asked this a lot. Every time I go on the radio, someone says, would you send your children back to school? And I said, I'd be so sick of them by now, I definitely would send them back. But I also think there's virtually no risk. There's more risk of them being run over on the way to school than actually from COVID for the vast majority of children. So the actual risk to the children of the virus, I think, is so minimal that giving them a good education far outweighs any potential risks. The big question really is whether children will transmit back to their parents and grandparents, and that's still less clear cut. And I think I'm less worried about parents, but for things like grandparents or vulnerable people at risk, I think we don't really know the answer to that at the moment. So I think everyone's got to make their own decision, and it would certainly be easier if people were deciding on this personal choice, also looking in that area to say, well, how many people are infected in that area, which would very much change your idea of risk, because there might be a threefold difference between areas. It makes quite a big difference if 1 in 100 people are infected, or 1 in 3 or 1 in 400 people or less are infected. So I think everyone's going to make those personal decisions, but certainly for the children themselves, I don't think there's a big risk. And what's interesting is most other countries have successfully reintroduced schools without any major outbreaks. There's a few exceptions, but they've been fairly local. And so I think that's reassuring.
There's a question here from Angela. Is it true that toddlers around the age of 2 going back to school, going to nursery, that the risks are minimal?
Yes. Well, I think the risks are minimal for all children. I think, people get very excited about these rare conditions, but it's, something like less than 50 children in the whole world have actually died of this. So far more children get, run over on the way to school than would have this risk. So it's not the children themselves you worry about, it's who they might end up coming into contact with if they did get infected. But obviously, in an area of low risk, that shouldn't be a major problem.
Yeah, and I think all I'd add on this is, and I think we've seen some questions coming through, so we're going to come back to this, is therefore I think it's fundamentally a question about the risk in people's households, that many people are in households where they themselves are not very high risk, in which case I think, Tim and I talk about this quite a bit. I have kids at school age. The cost to children of loss of education is also high, particularly in more deprived backgrounds, and the risk is probably quite low. Clearly, if you have people that you're living with in the household who are at very high risk, then I think that you need to take a different perspective. And obviously, it's part of why I think we in general think it would be nice to have the level of background infection much lower in the UK as it is in a number of other European countries, because then I think it would be a much more clear-cut question. I think it might be interesting, Tim, to just talk about the rest of these items as we think about the near term, because I think it would be, I think we sort of feel there's really these two phases. There's sort of what's the risk of a second wave over the next few months, and then really a second question about what it might look like from September on. I think to be interesting to talk maybe on these other points around sort of the near-term risk and how you think about the risk of a second wave over the next couple of months.
Yeah, so obviously loosening restrictions, I think we realize we sort of have to do it for economic reasons and also health reasons. More people will die of heart disease and cancer than from COVID if we don't get things back to normal, encourage our hospitals to fully open up and get all the staff back and get clear of this backlog. And also there are, potential mental health problems also for many people in this situation as well. We mustn't forget. I think there's some question about loosening restrictions. We do it all nationally here, and I think looking at other countries, Spain, for example, has 3 different levels, and each region of the country is allowed to go to a different level depending on how their hospitals are coping and what the level of infection is. It's unclear why we're not doing something similar here. Seems perfectly logical, and they're not allowing people to travel a lot between regions, so they can, you can really personalize what's going on, and this is what we mean by learning from other countries. So, most other countries have done better than us, and we really should be learning from them, and that's why, the Swiss and the Germans have been very relaxed about letting their kids go back to school and had not any problems. In the US, where they're equally unprepared, I guess, for the pandemic as us in the UK, and they did everything late. What's interesting is that then we're not seeing as many cases we might have expected from the rather chaotic response of different states. And that, I think, gives us an optimistic hope that even when you do things badly, it doesn't seem to go out of control for reasons we don't yet understand. I think that's what I'm learning from that hey, that's some potential good news on the horizon, that they still have proportionally less cases than we do in this country per million. And will track and trace help? Test and trace, as it's now called. The government introduced this as a magic bullet and world beating, and I think it's been admitted recently that it's certainly not world beating at the moment. The manual system isn't going to work very well where there's so many people with infection every day, and they're not picking them up. That's the other thing that the government was talking about. There are 25,000 people are not really working full time yet on this tracing because they're not being alerted to the cases. So again, if there was a more system-based, using our app was more widely used, they'd be picking up many more of these cases than is currently true. And the other thing is, test and trace has been suggested to only reduce risk of number of new cases by 15% at most. So we really need a suite of public health measures together to get this under control. Everything from social distancing, let's not forget the hand washing, which should be compulsory when you go to supermarkets, for example, and all public places, wearing a mask. We're, again, the last country in Europe to make that mandatory in certain places, and more and more testing. We still need more testing in hospitals and care homes to wipe out these epidemics. So it's everything together. There isn't one magic thing, and it looks like the Isle of Wight app may never get here in time for this particular epidemic. So we definitely can't rely on that. So in terms of what's in the future, it's going to be a while before universities go back full time. A lot of it's going to be online courses, but that could be particularly the schools could trigger another second wave. The weather seems to be important. A lot of people talking about how important hot, humid weather is in counteracting the virus. And that seems to be generally the case around the world, although Brazil you'd think would be spared more if that was totally the only reason. Everyone asked me about the vaccine. What's my personal view? I mean, nobody knows the answer, but from what I've seen of all the antibody results, which we can maybe discuss another time, I don't think that vaccines are going to be very easy, and we should, it could be that everyone responds differently. There isn't an easy solution. So I don't think we should be relying on the fact that there's going to be a vaccine. I'm pretty sure there isn't going to be a vaccine before the end of the year. So I think we've got to all look at these simple, cheap public health measures that we can do. But there is a role.
Just before Tim comes on to the last point, I think all I would just build on what he's saying, to be clear, is I think we do sort of think there's probably two phases. There's what we're likely to see between now and September, where, just as Tim says, I think when you look at the external experience, we sort of see a lot of that through the app reporting, as well as other data. It seems that being outdoors means that, combined with just much more cautious behavior by everybody, it's hard to imagine we'll be in the same situation we were in lockdown and a sort of exponential explosion of a second wave. When we start to think about September onwards and going, particularly in the UK, this is a fairly cold and wet island. It's a lot harder to imagine that we will be visiting our parents and sitting in the garden, in December. It feels as though at that point you start to switch the sort of the context in which the virus can transmit very significantly. And it seems that in an environment where R is only a little bit below 1, that's a pretty profound change. So we need to be in a much better place, at least as my own personal perspective, at that point. Otherwise, I think there's a very significant risk of a second wave, unless we have managed to really squeeze down the number of cases to the tiny numbers that we see in South Korea or Singapore, or even to some extent places like Germany.
Yeah, and just to finish off, if we can get earlier digital diagnosis, not waiting for because the fever, the cough, and even the loss of smell generally only occurs on about day 3 or 4, and so people have already been infected for a while. So finding ways to predict what's going on even earlier, so we can isolate those people and test their contacts, is the way to snuff this out. Otherwise, we're always going to be having these cases floating around, and that's one of the things that we're working on with the app, is to do this at a personal level, but also at a regional level. So working out when people, suddenly a blip of people just feeling unwell in one particular county or area would alert people there's something going on, and we can focus it. So we do need these digital helps. There's no one solution. Okay.
Tim, just touching on universities, Charles has asked, what's the impact on things like residence halls and classrooms, and what's the risk for university students versus children going to schools?
There seems to be certainly asking about the risk. The risk seems to go up gradually with age, but still university students have an incredibly small risk of actually having a severe illness or dying. Much more likely to die of other conditions, excess drinking, or again being killed on roads and things are far more common than anything. So I don't think the risk is to the students.
It's to the lecturers, right, Tim? That's the concern.
The aging professors and others who are lecturing is more of a worry. So they will definitely get it. Most of them will be asymptomatic or have very minor illnesses. There'll always be a few exceptions, but generally the risks are very low. But certainly those halls of residence would act as potential sort of breeding grounds for new infections that I think they'll have to start sorting those out and improve hygiene, particularly in canteens.
And it's a good example, I think, of exactly what Tim was talking about, why we're so excited about this idea of a digital diagnostic. If you have people reporting symptoms as soon as they're unwell and what they are, then if we can potentially identify fairly accurately, sort of instantly at the point that you've got enough symptoms to detect COVID, that's really the first point that you would even ask for a test. There's got a delay to the point you get a test. Today, there's at least a 24-hour delay until you get the results of the test. And that difference, even 1 day or 2 day, if you're imagining being in an environment like a university, we know that now it seems a small number of people are super spreaders. So a vast majority of people don't spread to anyone, and a small number of super spreaders spread to a very large number. The differences of just a few days is really what it takes if we want to keep this completely under control. So I think that's why, we're excited, and why I think, a really competent system of, being able to test very, very early is sort of central until the point that we have a sort of widely available vaccine. And as Tim says, there's a risk that actually means some sort of combination of multiple vaccines.
So I think it's the idea that, and we are hearing some people saying, employers or teachers or universities saying, okay, we want everyone to record their symptoms on an app for us, so we get an early warning of what's going on, as well as doing the hand washing, the wearing the masks, the social distancing, and all the other things. So I think that's what we really need to get together, and I think we need increasing consensus, from and you guys spreading the word about the app, about how useful it is. If you could see the benefits just from now, from getting 5% of the population using it. If you could get one whole area where you've covered at least 30% of that area with it, then it would be so much faster and better at doing the job.
Now, Tim, lots of questions about holidays. We've got an airline captain, Terry, who's tuned in, who's obviously interested in taking care of himself and his own health, but then what are we going to see happening in airports? What do you think is the reality of whether or not people can travel in the upcoming months?
Well, from what I've seen around the world, everyone's adopting a different position. The UK seems to be the most primitive in that it's trying to quarantine everyone, which is very 19th century type technology. And it makes no real sense quarantining people coming back into this country, because we have about the highest rates in the world at the moment of infection. Actually, they'd reduce, the more people that came in, they'd probably reduce our percent of infected people. But places like Sardinia, I know, are asking for people to have a swab test before they travel, and testing them at the airport when they get there for a small fee, and just told to self-isolate for 2 days until they get their result. And that seems a very sensible way to do things. There are rapid tests that are available in many countries, and in the UK, if only the approvals will be speeded up. A 20-minute test, which I think will be routine at airports, and with the sensible way around these rather ridiculous quarantine regulations, which aren't really going to be fit for purpose. So I think airlines will either be buying in bulk these kits, or the airport authorities, and that they may want you to also do a temperature check, a smell check using one of these various range of scents you have to spot. I think a variety of things, but I'm sure the industry will be keen to get going, and they'll be using everything not to exclude passengers who have infection, but just really make that number very small.
Now, on this topic of holidays, there was a question earlier around the east of England having higher infections. What's your view, Tim, on that? Because I think we can only make assumptions. We can't.
Well, I think we mustn't read anything into any one data point. And the reason we've talked about the north and the south is we've been seeing this consistently. So we will get blips in the data. So I wouldn't want to say there's definitely anything going wrong in the east of England. until I've seen another couple of weeks of data at the moment, given the number of users we have there. So I wouldn't get excited about any one thing on its own. You know, if all the data is pointing in the same direction, then we're really confident that's real.
Yeah,
I think it's a good transition to this, to the point on the slide, really, Sarah, which is the best way to answer that is, if you can encourage your neighbors and your friends in your area to use this app, then it suddenly gives us much more reporting in that region. One of the reasons that, in London, the data is very good is obviously there's a lot of people there and therefore a lot of people using the app. So we have very good data. So, we've been saying this just over the last week, but actually, now that we're coming out of lockdown and you're starting to see the decline come away, it's actually much more important now than it was in the past, to keep reporting every day, to try and encourage other people around you, because that's really the best way we have to know what's happening, rather than waiting, for, a month or longer to see this uptick of what's actually happening in hospitals.
Yeah, and just to underline that, really, we've got a lot of media from our science stories, but actually that doesn't shift the number of users much. What really shifts it is you guys sharing the data, telling people about it, acting as our ambassadors. And I think that's really important. So, we'd like you to really help us in this and get as many people in your circle and other ones, get other influencers on board to help us out, because it's through social media, it's through sharing the app that we can get many more people using it and make it an even more effective tool than it is already.
Absolutely. One final question for you, Tim. There are a number of questions around test and trace, whether or not we're going to integrate with the government's app. You've actually been invited into more conversations with the government. Do you want to give an update on where you think that's going to head?
I can't predict what the government are going to do or say, but I do know they are increasingly using our information. We're feeding into the SAGE group on a regular basis and the modeling group, and that's very encouraging, and that's how we know all about the official ONS surveys. I don't think until the fate of the NHS X app is sealed, whether it finally gets shelved or it actually gets rolled out, I have a feeling that it's going to be hard for the government to engage with us. But we are open to offers. There are branches of the government that are working very closely with us. The NIHR, the National Institute of Health Research, the Department of Health that's helping us with the swab testing. We may also be working with them on the antibody testing. There's a whole other group studying vaccines that wants to use the app users as well. So I think there's many ways we already are interacting with the government. Whether it's going to be, I doubt if it's ever going to be the official tool of the government. I think we have to keep paving our own way. And I think this is an advantage. It makes us much more flexible and responsive. And we want to work.
And I think all I'd add, Tim, is, Zoe is an independent company, and we're always going to make sure that what we do is put, our users first. It's really important. They put a lot of trust in us. They're sharing a lot of information. We take that incredibly seriously, as Tim does, and the whole team from King's College. So, we're very clear that, we will be focused on that. And the information that we're sharing is all the sort of information that you're sharing today that can really help all of us to fight the epidemic.
Absolutely.
Thanks so much, guys. Really appreciate it.
Yeah, thank you.
We really do appreciate it.
If you sent a question in advance and we didn't answer it on the webinar, which I hope most of them we did, you can visit covid.joinzoe.com/blog, and we'll work with our science writers and researchers to ensure that we're answering your questions. And then we'll also be adding something to the final screen in the app once you've logged, as well as sending an email out to everyone with a survey asking what questions you guys would like us to ask. So almost crowdsourcing what you guys want to learn through the app and how much you want to hear from us, what other data we can provide. So please take the time to answer those questions so that we can shape the learnings in the app around what you're interested in, as well as some of the scientific findings that, that our researchers are working on. Cool. Thank you for tuning in, everyone.
Thank you.